And then
Yes.
are most people online? I see maybe a handful of people in the room, but
Yeah, I'm going to admit some more people from the waiting room. No.
Yeah. ที่มีค่ะ
Hi, everyone. Sawadee. Good morning. Good evening. We'll begin in just a few minutes. There are still some people arriving online. We'll wait a few more minutes and then we'll get started.
ไม่ได้
Okay, Kate, are you ready to get started?
Sure.
Dr. Ratipon, can I ask you also to say some words of introduction?
Yeah, Dr. Ponsavan, the Director of Center of Nutrition, we will open our seminar. Please, Dr. Ponsavan.
เจ้าสบายดีตอนเช้าเรียนบรรณาธิการแบบที่มีเกียรติจากท่านผู้อำนวยการในระบบของประชุมแหล่งจานนอทีลาเป็นสลาวิลาเขาบวมในความหู้แก่สมบูรณ์ก็คือในระบบเนาะการมุ่งของรายคะแนนการได้จากปฏิบัติในงานโฆษณาการแห่งชาติ2025โดยเฉพาะการร่วมมือระหว่างศูนย์โฆษณาการในENGข้าพเจ้าดร.นางพรสวรรค์แก้วนครหัวหน้าศูนย์โฆษณาการรู้สึกเป็นเกียรติในมีความภาคภูมิใจเป็นอย่างสูงที่ได้ต้อนรับบรรดาท่านเข้าสู่การสัมมนาภายในหัวข้อปัจจัยทางสังคมกับผลได้รับทางด้านโฆษณาการหรือว่า Social Determinants of Nutrition Outcome ศูนย์โฆษณาการกระทรวงสาธารณสุขใช้โครงการสร้างความเข้มแข็งในการค้นคว้าทางด้านโฆษณาการ ANRCB Project ได้จัดสัมมนาในหัวข้อปัจจัยทางสังคมกับผลได้รับทางด้านโฆษณาการซึ่งการสัมมนาครั้งนี้จะได้ดำเนินการเสนอโดยท่านดร. Kate Eddens เชี่ยวชาญจากมหาวิทยาลัยจีน่าสหรัฐอเมริกาจะได้มาอธิบายเกี่ยวกับแนวทางการปฏิบัติและปัจจัยต่างๆของสังคมที่กำลังเกิดขึ้นในปัจจุบันที่มีผลทางด้านโฆษณาการซึ่งเป็นโอกาสอันดีที่ผู้เข้าร่วมในมื้อนี้จะได้เก็บกำเอาความรู้และหากบรรดาท่านมีความเห็นเรียนสามารถแลกเปลี่ยนและสอบถามนำท่านอาจารย์เพิ่นได้ต่อท้ายข้าพเจ้าหวังว่าบรรดาท่านผู้เข้าร่วมการสัมมนาในครั้งนี้จะได้รับความรู้อันใหม่ๆบรรลุผลสำเร็จตามจุดประสงค์คาดหมายอย่างสง่างามขอไปใส่พรให้บรรดาท่านจงมีสุขภาพแข็งแรงประสบผลสำเร็จในหน้าที่การงานถึงเวลาควรแล้วข้าพเจ้าการนี้กล่าวเปิดสัมมนาครั้งนี้อย่างเป็นทางการตั้งแต่เวลานี้เป็นต้นไปขอขอบใจ
Okay, Sabadi, good morning, everyone. Good evening to those in North America. We're very fortunate to have today for our third ANRCB nutrition seminar, Dr. Kate Eddens, Associate Research Scientist in the Department of Epidemiology and Biostatistics at Indiana University's School of Public Health. Thank you, Dr. Eddens, for joining us today, and the microphone is yours.
Thank you all, Sabadi. Yao Sabadi Bo. I think. Hopefully, I asked if you're doing well. Thank you for being here this evening and this morning. And please, as I'm talking with you today, feel free to ask me to slow down or repeat anything that's needed, as I'm grateful we have a translator working with us this morning as well. But I want to make sure that I'm not moving too quickly. And can everyone hear me okay? I'm going to take that as a yes. So today I will talk a little bit with you about my background and some models of social determinants of health, and specifically network and social network determinants of health disparities or health inequities, and how we can apply these to nutrition and help build a multi-level model of nutrition outcomes for your work and how I may be able to help serve you in meeting some of your nutrition research goals. So my background and training are in social epidemiology and social network methods and analysis, applied health communication science, and in developing technology to reach populations affected by health inequities. And as a bit of background, I completed my Master of Public Health in both epidemiology and behavioral science, and began my doctorate in epidemiology at one school and moved to another school, Washington University in St. Louis, and that was in public health with a focus on social determinants of health. I was also trained in a Center of Excellence for Cancer Communication Research, where we focused exclusively on creating and testing health communication strategies for prevention and screening of cancer among racial and ethnic minority populations. And I mention all of this background because for a few reasons. One, because having a dual degree in epidemiology and in behavioral science has helped me both research and understand the health problems, as well as research and develop and test interventions and solutions, which is important to me in doing applied work. I became an expert in social network methods and analysis through my work with a few different centers here. And to get up to the present, I had a position at the University of Kentucky College of Public Health, where I focused on inequities in rural Appalachian people in Kentucky, which is one of the poorest and most isolated areas of the United States. I moved to the Indiana University Network Science Institute to further develop this interactive data collection platform called ENSO that collects both network and survey data. And this brings together the components of all of my training to enable measurement of social determinants of health and the development of interventions that can then leverage the power of social networks and health communication to reach people and connect them to health services and support that they need. And when I talk about inequities or disparities, I'm talking about creating solutions that give everyone the support they need to produce equity. So I don't want to refer to equality, which while delivering the same supports to everyone can make differences worse. Of course, the goal is to create a system and a world that is just and inclusive by removing these systemic barriers, like you can see in the images, removing this fence that's preventing people from being able to see. And then including everyone in solutions in which they feel valued and involved. But this can be very difficult to do. This is a model of social determinants of health outcomes by Lisa Berkman and Thomas Glass. I know this is very busy and overwhelming to see, and the text is very small. So I will be simplifying this in slides moving forward, but I wanted to show this to you as the fundamental model from which I derive my working models of research and intervention. And what this shows is that upstream, these socio-structural conditions like culture, socioeconomic factors, politics, war, social change, these shape our social networks and the people that are around us, which then provide opportunity for these other mechanisms like social support or influence or even person-to-person contact to impact our health through multiple different types of pathways. And so we'll talk a little more about some of these in detail. Are we doing okay with speed and in translation and everything? Everybody good? So essentially, this social ecological model says that we don't exist in a vacuum. We are influenced knowingly or unknowingly by the people around us, by the organizations that we belong to and the cultural institutions, the communities that we live within, and the policies, laws, and culture of our society. This is a dynamic relationship, but much of the influence flows from the society and policy level down to shape our communities and institutions, which shape our social networks and then shape us and our own behavior. So we can take that complex Berkman and Glass model and simplify it, add in some concepts from communication research, and distill it to say that our social networks and environment are powerful influences on what we know, what we think, what we have, and what we do. So if our social conditions determine who we are around and who is around us, think of where you grow up, the kind of politics and culture of your community, where you go to school, who lives in your neighborhood. These often determine who we make relationships with. So our networks of relationships then create opportunities to access support, like social support, emotional support, financial support, resources. Those can be food, it can be housing, it can be our basic needs, and information, which is essential to being able to make health decisions. And all of these then contribute to our health outcomes. And none of these exist without the influences of the others. And this is one of the most important concepts or messages that I want to get across today. And that is that we all make choices only within the context, our own personal context of opportunity and choice. So we make our choices based on what we see as being available to us. And that might look different than what is available to someone else that we know, or to what other people think we have. So this doesn't work equally for everybody. These social conditions that I mentioned, like racism or geographic isolation, war, poverty, specific types of economies can make some people's networks, for instance, smaller or more constrained, where they're only made up of certain types of people who are all alike. So sometimes our networks are filled with people who are just like us, and they know the same things that we do. They have the same resources and information, and that can be challenging when we need different resources and information. So it's very helpful when you need social support and emotional support, but it's not great when you need that opportunity to access new information and new types of resources that may be different than what everyone you know already has. So, and when the norms or beliefs or values of most of the people in your network are harmful, such as believing a vaccine doesn't work, or when everyone you know smokes cigarettes around you, this can have a negative influence on your own behavior, or can create barriers to your ability to hold differing beliefs or to engage in different behaviors that could be healthier for you. So this network support and access to resources and information then greatly influences your health behaviors and your health risks, and both psychological and physiologic aspects of health, like stress or malnutrition. So if your network is healthy and filled with lots of diverse people who give you support and money and access to new information and opportunities so that you're constantly evolving, that's great. But if you don't have a network like that, and many of us don't, then that can really hurt your opportunities to make healthier choices, to reduce risk, and to have healthy outcomes. Many people are also unaware of the resources that are embedded in their networks or their environment, and how they can leverage these resources to support their physical and mental health and well-being. When we think about social capital, for instance, there are 3 conditions that need to be met. You first must have resources in your network. Second, you have to know those resources exist. And third, you have to activate your network to access those resources. And those are 3 big steps that can be difficult to take for many people. So with the background in health communication, we were trained to address health inequities by improving the reach and effectiveness of health communication and connecting people to services and solutions. So the key to this approach is that in order for communication to help address inequities, we have to do a better job of reaching people affected by inequities, providing information that's actually meaningful for people in the context of their lives, and then going beyond providing that to connect people to services and solutions. Social networks are an important part of public health and are one of the fundamental methods that underlie a lot of the research that I engage in, and much of the research on social determinants of health, even though we don't always measure or describe social networks. Sometimes we use terms like social capital, social support, or our systems and environment, which include networks, but we're not necessarily using network methods to enumerate those pieces of the social determinants of health. So when we use networks to understand problems and solutions in public health, we often use them to understand transmission of infectious diseases, like this network, the first cases of HIV in North America, or we look at how behaviors or risks spread, such as in this network that traced obesity in participants in a longitudinal Framingham heart study. We can also use networks to understand social support and social resources. In the middle on the top is a network of stroke patients to see how who they are around when they have a stroke determines whether they're going to make it to the hospital in time. And this other network is of trusted sources of health information in a community in Appalachian, Kentucky. So they all look very different. And there are a lot of different uses for networks in understanding health outcomes. While we may use them for multiple different outcomes, transmission, social networks, and organizational networks, we'll focus more today on transmission of information and resources, social support and capital, and network influences on health behavior. So one important component in understanding networks and how they affect health outcomes is that structure matters. And a node, that's just any person in a network or an organization in a network, determines the opportunities or restrictions that it encounters and then plays a role in the node's outcome. So we often don't see the structure of our networks. We just think about them as the people we're around or the organizations we're a part of. But the structure, when we're able to move out and see it, is very important. So how can these networks help us understand health disparities? First, by helping us understand complex systems in nature, society, and science. So I showed you a little of the ecologic model. I'm sure that many of you are familiar with that as well. And system science, which says that the whole is greater than the sum of its parts, that you can't change one piece of a system without affecting other parts of the system. And also the mechanism of network influence. So there's reciprocal influence. We affect the people in our networks and they affect us as well. Who is in our network? Who are the people that might be influencing us positively or negatively? Again, that this structure matters. Social networks, they're not random. There are structures, particular structures allow or inhibit certain effects. So there are purposeful ways in which we can create our networks or in which policies that we institute, the communities that we're a part of, are shaping the networks that we're in. When we look at the relationships in networks between people, we look at things like similarities, how nodes, and nodes again are the people, might be alike. Are you family members? Do you have the same gender? Do you share meals together? Do you shop at the same market or stand for your food? What kind of relationship do you have? Do you know one another? What is your role? And what interactions happen between those people? Is this someone that you talk to or get advice from? Is there physical contact? And what's transmitted between the nodes? Is it conversation, information and beliefs, infectious disease, which is something we all talk about a lot now, resources, money. And we know that these networks influence mortality. There's about 30 or the network effects on public health have been around for since the 1800s, when we looked at social isolation and suicide. But over the last 30 years or so, there's been a great amount of evidence looking at how networks influence mortality, disease incidence, health-related behaviors, and again, this opportunity for information and resources and support. Social epidemiology is an important component that uses network analysis to find how our networks play this role, often a mediating role between these other social conditions and our health outcomes. So the way that racism may play a role in your society, or poverty, there are going to be very different types of networks for people who have a great deal of wealth and for people who do not. There are different networks for racial minorities in a society and the majority in a society. And once you begin to make that separation, often the outcome gets further and further apart as you move down the line from social networks through these mechanisms to the outcomes. They also help us to create effective ways to intervene on health behaviors and risks and outcomes. So how can we intervene on networks? If we revisit this model, we know that we all would love to be able to change these social conditions. And in some structures of governments and institutions, that's actually easier to change social conditions and policies to affect communities. In other systems, that's not very easy. In the United States, it's very difficult to change social conditions. It's difficult to change policy. It takes a long time. And then it takes a long time for those changes to take effect. So it's often the end goal here. It makes the biggest impact, but it's harder to do. So, these policies and laws and culture are deeply embedded, and they're often rigid and difficult to change. But we can intervene with networks in many ways. We can add people to someone's network, say by including them in a peer group, delivering interventions in community groups like temples, churches, schools, where they're embedded in networks with peers. You can increase the amount of support or resources or information that are provided in networks. And I'm going to give you one example of an intervention study that I worked on using health coaches to help low-income people in the United States to connect to health services they needed. So in this particular study, people were calling, it's a 3-digit phone number, just 211. And when you call this in the United States, it's a social service hotline. So you can call this number when you need help for basic needs like food, shelter, paying bills. Where I live in Indiana, you can also call it to get an appointment for a COVID vaccine. There are a lot of services that are delivered through this 211 phone number. So we worked with a 211 system in Missouri, in the United States, where people who were calling 211 because they needed help with their rent or connection to a food pantry. And the 211 call system helps the person with those basic needs. And then they screened them for some basic preventive health services. And we tested 3 interventions: delivering referrals to these health services over the phone, delivering those referrals over the phone, plus adding a tailored magazine that was sent to their home with information about the referrals. And then third, connecting them to a health coach. And it was these 2 particular women in the photo, Tiffany and Nikki, were the health coaches. And this was primarily in an urban African-American community in Missouri. So it's always important to have the people who are doing the coaching be similar to the individuals that they're helping. And so what the health coach could do was talk to the people who had the health needs, help them make the appointments for the referrals, and talk them through questions they might have. So one of the most important outcomes that we found in the study was that callers who had the reason they called the hotline resolved, so who had those basic needs resolved, had higher odds of contacting the health referrals. Why? Because it's challenging and sometimes impossible for people to take care of their health when their basic needs like food and shelter are unmet. We also found that this health coach arm was most important for those with a high number of unmet basic needs. So people who were going month to month, not knowing if they were going to have a place to live or enough money to buy food, and for people who had low social support. So they didn't have very many people in a network that could support them. And for people who didn't get a provider recommendation. This specifically was for mammogram, but for people who didn't have a physician who was saying, you need to do this. So this was important. As a network intervention, it may not seem like it's a network intervention, but the people who had low network support and network resources needed the help of a coach to act on those referrals. And in this case, the coach is serving a role in the participants' network. They need that extra help that doesn't already exist. And over the course of several studies, we've looked at how people's environments and social networks, their social determinants, affect their ability to access health services and engage in healthy behaviors. Much of my background and my work has been in health services and cancer prevention and control. You know, a lot of my role in the Applied Nutrition Research Capacity Building Project is in methods. I'm a methodologist and help with research and survey design and methodological methods and analysis. It's less in the nutrition expertise of many of my colleagues who are participating in this as well. But nutrition and access to food always plays a role when people have unmet health needs and when they are, when we're looking at how social determinants are impacting health outcomes. When, you know, time and time again, we find that healthy networks and that support healthy behaviors and access to resources are important, but they're not sufficient when people's basic needs are not met, or when the culture or policies in their communities create barriers to healthy outcomes. I'm actually going to skip over this, and one more little piece of how social isolation itself contributes to mortality. There have been 70 independent prospective studies over, within a meta-analysis that over an average of 7 years of prospective studies found that social isolation specifically affects mortality. It also affects obesity and smoking. We found, and I did a study with some colleagues at the American Cancer Society who had a 30-year cohort of survey respondents. And there are all kinds of little confounding factors that play into that because it is a survey. But we wanted to understand what the relationship was between social isolation and mortality, and whether it differed by gender and race subgroups. And we specifically looked at Black and white women and men in the United States. And what we found is that it is different based on both your gender and your race. And what we found that, for instance, Black men who were not married had the highest risk of mortality, and that there were certain types of relationships that were important based on gender and race. So for Black women in America, attending church regularly was an important factor to reducing mortality. For white women, it was having friends. For men of any race, it was being married. So unmarried men don't do well in the United States. But this was just a kind of a large overview of how isolation can affect people and contribute to death in the US. It is an independent risk factor for death that was on par with physical inactivity, obesity, lack of healthcare access, current smoking, and having diabetes. But we don't measure this. We don't go to the doctor doesn't say, do you have people in your life you can count on? And one of my goals as a researcher and applied scientist is to make that happen someday, and to help create these kind of risk profiles so that when someone walks in, if you are seeing an older, unmarried Black man in your clinic as a physician, it should be an automatic part of your care that you ask this man about his social connections. I believe we should be asking everyone about their social connections, but it's more important for certain subgroups of the population. So this is just yet another example of a social determinant of health outcomes that we don't necessarily think about regularly. I think we have thought about it a lot more during the pandemic because social isolation has become much more visible and more of us have experienced it. So in this study, we found that yes, lacking social connections is deadly, and that people, everyone could benefit from participating in more groups and clubs. Men, I mean, we can't assign men to an intervention where they get married, but that unmarried men have a higher risk. But these things are hard to change. Things like obesity are hard to change in the United States when we are where we are with the obesity epidemic. And you all are still in this very beginning stages where there is action that can be taken. And so one question I have is, what is the state of social connection in Laos? And how has that been affected in the past few years with the pandemic? And I want to move into a more, if this is possible, if we can make this work. I know this is difficult with the Zoom, but in something that's more interactive, where we can take ideas from this model and apply them to the context in Laos to talk about how these social determinants can affect nutrition outcomes. So I wanted to start by asking, what are some of the nutrition outcomes that you are interested in specifically? And maybe if you are able to, if you're in the room at the Center for Nutrition, if someone could write them on the whiteboard, or if you're in your own office, if you want to jot down some of your outcomes of interest. I know from our experience there, breastfeeding is very important. We had research teams. They're interested in both obesity and in other types of malnutrition in adolescents, in young women, in children. I want to start with just what are some of the nutrition outcomes you're interested in, and then I would like if we can work together to talk about some of the factors in Lao PDR that are contributing to these outcomes, and begin to look at the way that these factors are related to one another and where there may be opportunities to change those relationships. Can I ask you all if this is something that is possible to do? If anyone at the center of Dr. Lot could let me know if this is feasible.
Today date. Là tham từ đây có đến.
Can we let people unmute to some extent and maybe contribute some?
Most people are joining virtual. They're not at the center. So if you want to ask them to unmute and comment, I think that would work.
Okay. If anyone would like to unmute and even begin with an outcome of interest. So I've met some of you now. I can start calling on you. If we think about these, looking at these different components of this model, what are some of the factors in your communities that you feel contribute or important contributors to some of the outcomes that you're interested in changing? Is there anyone?
พิ่นจะให้เฮายกอยู่บ้านเฮาบ่
เราทำส่วนตัวผู้ใดมีอย่างที่เสนอเด้อว่าสิ่งที่เจ้ากำลังเฮ็ดเวียกที่เจ้าอยากเปลี่ยนแปลง อันเสนอหัวข้อแบบว่าการกินอันของพวกนี้พวกนั้นหรือว่าอันปัญหาอันใดที่ว่าresearcher เฮาอันสนใจเปลี่ยน
อยู่บ้านเฮานี่ส่วนหลายกับปัญหาเรื่องอัน behavior นี่เนาะเรื่องอันการเปลี่ยนแปลงทางด้านพฤติกรรมนี่แหละบางเทื่อเขาเจ้าก็มีความรู้มี knowledge แล้วก็เขาเจ้าก็รู้เรื่อง information ก็รู้แต่ว่ามันจะเปลี่ยนแปลงพฤติกรรมมันนะค่อนข้างจะยุ่งยากหลายเนาะมันมีหลายๆปัจจัยนะเพราะฉะนั้นเฮารัฐบาลเฮาก็เน้นใส่เรื่องอันเปลี่ยนแปลงพฤติกรรมแต่ก็มีหลายอัน study เขาเจ้าเฮ็ดออกมานะแต่ว่ามันก็ยังยุ่งยากอยู่
Did that come through okay, Kate?
No, I'm sorry, I did not.
Okay, so you're not on the English channel. So
I am.
what you're saying is that the issue is that we know what people need to change. We give knowledge about nutrition, but getting them to actually change their eating behavior is very difficult. And that's even government's done research, but we don't see a change in the behavior.
Yes, yes. And that is, so in that, yeah, I think it's a big shift in recognizing and understanding that individual behavior is very difficult to change, and people don't really change, specifically with education. You have to change all of the context of their life in order to do that. I know when we were there and I think Ramya was asking about what you ate. If I could ask, who are some of the people that you eat with? Who are some of the people that you shop for food with? And who are some of the people you have to feed? Because I think those are some of the most immediate, even network influences on the way that we eat. I think I'm on the English channel now. If anybody would want to contribute ideas of who they eat with or have to feed, what are some of the people around them for when they're eating?
Yeah, good morning, Professor Kate. Yeah, I think that it's very important to notice about the changing behaviors among the people who living in the developing country or in other country as well is quite challenged. And from my notice that from the Lao cultures, mostly that it depends. I think that it depends on the size of their living. For example, when I noticed about people surrounding me who living in the cities and people living in the rural area, the most of the city people, they often have their food from the outside. I mean that not the home cook, but in the rural areas, mostly they quite prefer to get the home cook rather than eating outside. So the impacts of the changing behavior is quite different. If we compare in the city, they have many influence factors, for example, like the living style changing from the other culture influence. For example, like for the teenagers, they might have their model from the televisions that they want to maintain their weight or their shape or something like that. But for the other group, the eating behavior might not different. It depends on the age. Yeah, that. And I would share that from my notice.
Yes, Hey, thank you so much. And that's huge. That's very important. And knowing that the type of behavior change we try to introduce to someone in the city versus someone in a rural area is going to be different because they're engaging in different types of meals outside the home or home cooked. And like you said, depending on age, they may be trying to maintain their weight or look like a certain role model, and others are not so concerned about that. And I think one of the keys to this type of modeling is recognizing that all of those influences are playing a role together on individual behavior. So if you approach two different people with the same type of education in nutrition or eating, they're not going to work the same. And that's important. And I think that's the goal here, is to try to really drill down into those specifics and be more precise about how you deliver intervention and behavior change. So if you want, for instance, here in the US, when we're working on diabetes, it's very difficult to get a man who is married and has a family, and perhaps his wife is doing a lot of the cooking. And if she's controlling the cooking and she's interested in helping her husband be healthier, you're going to have a better outcome because she's doing the cooking and he's going to eat it. But if it's not that kind of a family structure, it's going to be very different. If it's a woman who is living alone and does all of her own cooking, that's different than someone who has to make food for a whole family. So, and again, that will differ from whether you live in a neighborhood that it's too dangerous to even walk down the street to go to the market that has fresh fruits and vegetables. Instead, you have to, go to the place that's right on the corner that only has processed and packaged foods. So all of these factors play such an important role that we have to recognize that we can't use these general kinds of interventions and education approaches for everyone. What are some other, so we kind of talked about the urban and rural, what are some other more upstream factors that you find are influencing the way that people's networks are shaped? So how does somebody's network of people they're around all the time, how are their relationships different for someone in maybe in a rural area versus someone in an urban area? If you think of someone in an urban area and someone in a rural area, who are they interacting with most regularly? Who are they seeing on a daily basis? And how might that affect what they eat or how they access food? I know that we had talked about how some, some families who may be growing more food at their home still, have to maybe away from their family to live in a certain spot, to work, to grow certain types of food. So the way they eat there is different than they might eat when they're at their home other parts of the year than during this season. All of these are pieces that are going to impact the way that you structure interventions for people. How much time do we have? $10:30. Okay. If we can take this kind of model, or going back to the Berkman and Glass model as well, that had a little bit more detail in it, and take an outcome that we're interested in and begin kind of filling in, looking at this and filling in the different components of factors that contribute to the health outcomes. One thing that we can then do is the system. I don't know if this will work, but I want to see if maybe, no, maybe this won't. Can I go back? Shoot. Well, what I was hoping to do was if we have that model and you can begin listing some of those factors, and then if you can draw kind of a plus and a line between the ones that may reinforce, or a negative line for ones that kind of inhibit the relationships between these factors, you can begin creating essentially a model of a system in which you're working, and identifying areas in which you can begin to create interventions or change policies to address the factors that are reinforcing or mitigating one another. And this is a bigger exercise that I would love to help any group do more in person. We can even create networks of both people, but also organizations or factors that are involved, contributing factors in a model of nutrition outcomes, and begin to lay this out like a map and start to understand where there are points that interventions can be delivered, and prioritizing those as well by what is going to be a more easily changeable factor and what's going to be very difficult, and where do those things meet in a place where, okay, well, this might be harder to do, but it's really important. We should focus here versus somewhere else. And I know that all of you, given the positions that you're in and the work that you are doing, you're doing this. You're doing this already. I'm hoping what I might be able to help with is providing an opportunity to visualize many parts of the system and look at the ways that they're working together, or kind of fighting against one another to create conditions that aren't ideal for achieving your nutrition outcomes. So I would would like to just end this part there and say that if you have, well, shoot, I can't get it to go off. Wait, hold on, maybe this will work. I'm trying to get to my last slide that just shows you my information that if you would like to reach out and have more conversations about this or work out a way to meet more in a group or individually to do some of this mapping, I would be happy to do that. I feel like there was only a tiny little bit that I could share with you in a shorter amount of time and from a distance. So I hope that this was in some way helpful, and I'm happy to get any questions that anyone has or comments.
Okay, please join me in thanking Dr. Eddens for the presentation. And I think she's available for questions now. If anyone wants to ask questions, please switch to the English language channel. And I think our interpreter is available to interpret questions. You can ask your question either in English or in Lao. No questions? Well, Dr. Eddens, I don't believe there are any questions at this stage. So again, thanks for the presentation, and we'll be distributing the slides to those who are interested. So Dr. Ratipon will have the slideshow available for sharing. Okay? Thanks, everyone. Have a good day.
Thank you.
Yeah.